Hello, everyone. Welcome to today's session of the Harvard Medical School's Organizational Ethics Consortium. I am Charlotte Harrison, and I'm one of the co-chairs of the consortium along with Kelsey Berry. I have the pleasure of being your moderator today. More in a moment about our panel. But first, I'd like to share a quick introduction to this consortium overall. In parallel with our companion series on clinical and research ethics and public policy, this consortium focuses on action at the organizational level. How do organizations build internal structures and culture to facilitate ethical practice, working with limited resources and other constraints, and attending to multiple stakeholders, as well as to moral diversity and uncertainty? You can see on the present slide the topic of next month's consortium, as well as other ways you can be informed of upcoming programs. Today, we look at an issue that has plagued healthcare organizations since well before the COVID-19 pandemic, though most pervasively during that period: how to allocate scarce life-saving resources when there are not enough to offer every patient who could benefit. In particular, today, we look at extracorporeal life support, ECMO, and related modalities, which have made it possible to support both heart and lung function for very sick patients in the ICU. Whether there's a surge in patient numbers or in the case we're going to discuss today, a shortage of supplies to complete a circuit, patients may die because we don't have the equipment we normally count on. Today, we'll hear from a team at Seattle Children's Hospital where the recent prospect of such a shortage of ECMO circuits led to an organizational process to develop triage principles and protocols that could be understood as ethical by patients, the public, and the clinicians who would need to follow them. We'll hear about the development process itself, as well as the substance of the approach that was chosen. Now, a word about how the audience members can participate in today's program. One, you can use the chat box to share your thoughts at any time during the program, or once we turn to Q&A, we encourage you to use the hand raise function to signal that you'd like to speak your question to the panel yourself. So now I have the pleasure of introducing the panelists. I'm going to tell you about them in the order in which they'll speak. Our first speaker will be Dr. Douglas Diekema. He's a professor of pediatrics at the University of Washington School of Medicine, with adjunct appointments in the Department of Bioethics and Humanities in the School of Medicine and the Department of Health Services in the School of Public Health. He serves as co-director of education for the Truman Katz Center for Pediatric Bioethics at Seattle Children's Research Institute. He's been a member of the Seattle Children's Hospital Ethics Committee since 1991, served as an ethics consultant for many years, and founded the Center for Pediatric Bioethics at the hospital in 2004. Doug will start off our presentations by talking about the Northwest Healthcare Response Network, with which he's also been involved and whose work helped to lay a foundation for the process at the hospital that will be our primary topic today. Our second speaker will be Dr. Emily Berkman. She's an assistant professor in the Department of Pediatrics, divisions of pediatric critical care medicine and bioethics and palliative care at the University of Washington Medical School. She attends in the pediatric intensive care unit at Seattle Children's Hospital and is on the ECMO team. She's a member of the Truman Katz Center for Pediatric Bioethics and the convener of the Pediatric Organizational Ethics Collaborative at the American Society for Bioethics and Humanities. Emily is also a co-founder of the Organizational Ethics Consultation Service at Seattle Children's. In her talk today, she'll share some organizational context for the ECMO Triage project that is our focus today. Finally, to help us reflect on the presentations from Seattle, our discussant will be Dr. Wynia. who is the director of the Center for Bioethics and Humanities on the University of Colorado Anschutz Medical Campus. 2 years ago, based on his work in public health and disaster ethics, Matt joined our organizational ethics consortium to lead a program on the ethics of hospital transfers in the COVID-19 pandemic. We brought together public health and hospital leaders from states that had activated regional or statewide inter-hospital transfer systems. And we're happy to have him back to return to a related program. For today's program, Matt also brings the experience of several decades in organizational leadership. Among other roles, in addition to his current center leadership, he's headed the Institute of Ethics at the AMA in Chicago, the American Society for Bioethics and Humanities, and the Ethics Committee of the Society for Internal Medicine. He's also on the Fellows Council at the Hastings Center. Following Matt's initial comments, he'll lead an interpanel discussion as a bridge between the presentations and the audience Q&A. We're delighted to have the four of you with us. And with that, I'll turn it over to Doug to get us started.
Thank you, Charlotte, and welcome everyone. It's a pleasure to be here and I'm honored to be invited to begin the discussion on this topic. And I thought I would start at this turning point in history, which was January 2020, when we first heard about this novel variant of the coronavirus. And it was only a couple of weeks later that the first identified case in the United States occurred a couple miles from where I lived in Snohomish County, which put Washington State on high alert and resulted in ultimately these sorts of headlines about the kinds of decisions we might have to make during the pandemic as we became overwhelmed with potentially sick patients and did not have enough resources. Now, fortunately, Washington State had been preparing for something like this since about 2006, when a regional healthcare coalition was established that involved many, if not most, of the hospitals, clinics, and health departments in the state. And we began working on materials related to crisis standards of care for a disaster scenario. And I was involved fairly early on in those discussions. And to be honest, we were looking primarily at disasters that included an influenza pandemic and things like earthquakes, which we worry about in the Northwest. In 2012, those groups combined to form the Northwest Health Response Network, which was sort of housed within the Seattle-King County Public Health Department. They became an independent nonprofit organization a couple of years later, and then the State Department of Health contracted with that group in 2017. And at that point, it became a much more prominent statewide organization that now includes Eastern and Western Washington and the majority of hospitals in the state. So we had the advantage that this group had been working for years prior to 2020 to establish materials related to shortage situations. And you can see on this slide the large percentage of the state that is actually included in this network. The network has what's called a Disaster Clinical Advisory Committee, whose role was to advise in the event of a disaster, and also an Acute Infectious Disease Advisory Committee, which obviously became helpful during the pandemic. Most of you have probably seen this schematic. This schematic largely drives what our network does, where we think in terms of stuff and space and staff, the sorts of things you might find in shortage, and then how we would respond to the various levels of crisis with, conventional operations. Everybody knows how to do that. Contingency operations where things are beginning to become in need of some care in distribution and use, and so there may be some change in quality, but in general, the patients are not being put at significant risk. And then crisis operations, which is what we worry the most about, where we really and truly don't have enough resource, whatever that resource may be, to take care of everybody who needs it. And in thinking along those lines, the Northwest Healthcare Response Network developed a number of materials to address how changes might be made in contingency mode and how they might be made in crisis mode. And this shows you a few of the examples of materials that were created. If we don't have enough staff, if we don't have enough ventilators, if we don't have enough medications, how might we distribute those or alter the way we distribute those in a way that optimizes our ability to care for patients. This just gives you an example of what those materials look like. The details, obviously this is too small to show you the details, but I wanted to share with you, sort of briefly what the mechanical ventilation one looks like on the surface. And there's a link there. These are all publicly available. You can get a PDF that basically includes all of these materials that we used and revised during the pandemic. Now, as background, the sort of framework that was used in developing these materials was really the sort of recognition that in a public health emergency, whatever that may be, there to some degree needs to be a shift from a beneficence-based practice of medicine and healthcare in which clinicians take care of individual patients and prioritize the needs of the patient in front of them, to the principle of justice, where there is a requirement that we respond to the needs of a population. And in doing so, that may require clinicians, hopefully in a way that's being governed at a higher level, to prioritize some patients over others. And there's a recognition that this can be very difficult for clinicians who have really been trained to prioritize the patient in front of them, to now sometimes have to be involved in really difficult decisions. The general principle of disaster triage is really at least a modification of a utilitarian approach, where the goal is to save as many people as possible by treating those who are the most likely to receive benefit, and also combining that with using the fewest resources possible. Over all of this is Aristotle's formal principle of justice, which requires that as you create a distribution scheme, you try to treat everybody similarly unless there's a good reason to treat them differently. And so that reason has to be relevant and it has to be justifiable. And so, to give you an example, these are 4 ways that we distribute scarce resources in different realms. And I think what the formal principle of justice would say is that what's relevant and justifiable depends on the situation you're in. So, to give you an example, promotions at your workplace are generally distributed based on what's considered relevant and justifiable, which would be merit, deserving, effort, those sorts of criterion. Markets and investments are based on reciprocity. The more you put in, the more you're likely to receive out. And it's not considered unfair that a person who invests more receives more in return. There are some things like the laws that are supposed to be distributed or enforced equally. Everybody should be subject to the same sort of application of laws. If the only thing that should matter is that the law is broken. And then we generally feel like in the healthcare arena, the only relevant criterion is really need, medical need for whatever it is that's up for discussion. And so we tend not to distribute or talk about distributing healthcare goods based on merit or reciprocity or equality, but rather on need. The way we thought about triage with most of our materials was that there would be eligibility criterion, and those would be based largely on an individual's potential to benefit. In other words, if there was no potential to benefit from, let's say, ECMO, they're not eligible. And the patient should also be willing to accept treatment. So Larry Churchill, for example, has written eloquently about his thoughts about somebody at his age who felt very strongly that he would refuse treatment if there were people who were younger than he who would also be eligible. And although he didn't necessarily make an argument that age should be a criterion, in his own personal sort of ethic, he felt that his decision would be to not allow himself to be put in front of the line in front of somebody else. Once you've got an eligible population, then you have to decide who gets first in line. And the three criterion that I think there probably is the most consensus around is that the patients who need the resource the most should be put up there. Those who are the most likely to benefit from the resource should be toward the front of the line, and those who perhaps require less resource should be near the front of the line. And then if you have people who are very similar with regard to those criterion, you use some kind of a tiebreaker. Now, what we settled on during COVID, what we recognized very quickly was that we defined likelihood of benefit as survival to discharge, but we also found that with that particular virus, it was very difficult to predict how long somebody would need to be on something like a ventilator. And it was very difficult sometimes to decide just how badly somebody needed it, because generally by the time they were needing a ventilator, they all needed it. And so we really, for that particular virus and particularly in the mechanical ventilation realm, decided that likelihood of benefit really was the criterion. And then we also decided that a random allocation scheme as a tiebreaker was more fair than first in line, which tends to preference people who are privileged in other ways. On the ground, the committee, the network had weekly meetings so that everybody was on the same page. The governor attended a couple of those. There were subgroups created that were meeting on a regular basis to revise materials. One of the things I think we learned from the pandemic was that although we had materials in place, the COVID was different enough from influenza that we needed to alter those materials a little bit. And then it was also important for us to get input from stakeholders to see, particularly persons with disability and people of color, to see if the criterion we were using in some way disadvantaged them unfairly. And then individual hospitals focused on implementation of these principles. The governor was very clear that he expected resource sharing across the state, and his principle was no hospital would declare crisis standards until all were at a place where they needed to do so, so that we didn't have a hospital across the city, for example, rationing ventilators when there were 3 of them available at my hospital. We also felt very strongly that triage teams should be implementing these sorts of criterion and making decisions rather than bedside providers when possible, in an effort to remove the burden from bedside providers, in an effort to provide an objective, more evidence-based measure of medical factors. and to some degree to blind the triage teams in a way that clinical teams can't be blinded to factors that are irrelevant to who might benefit the most. And triage teams also then might also have more situational awareness of the regional needs. Now, as far as lessons learned, we learned one of the things that I think I certainly found fascinating was that the principles of fair distribution to some degree held from resource to resource, but allocation priorities, in other words, who would get the resource, differed depending on the resource in question. And I think this became most clear during the pandemic, for example, when we were initially talking about ventilators, where we were prioritizing the sickest patients, and then we found ourselves talking about who would get the vaccine first. And it was no longer the sickest patients who were going to get the vaccine, but we had to figure out, who actually would derive the greatest benefit, and where the population would benefit the most in distributing those. And it turns out that with preventive measures, it's almost an entirely different group of people that would be first in line. Reassessment and refinement of the process was essential, and that was done throughout the pandemic. And a centralized process, we feel, is really important for this to be fair. And equity requires attention to access, and efforts needed to be made. And we were probably more successful with vaccine distribution at paying attention to access than other things. I'm going to end by just pointing out that these are tragic decisions. And as Stanley Hauerwas points out, although we'd rather not face the truth that we live in a world where sometimes we can't always achieve the best results, and we don't always have enough for everybody. And so tragic choices are going to be necessary. And the discussion we're going to move into now with Emily and Mithya will demonstrate how we're approaching those tragic choices with some of the questions that have come up surrounding ECMO more recently. So Emily, I'm going to turn it over to you.
Thanks, Doug. All right. You guys able to see my slides? Great. Well, thank you so much for inviting me to speak with you today. I get to tell you a story, which is really fun for me. And as Doug mentioned, a lot of work had been done already to try and think about how we would deal with resource scarcity. And so I'm going to talk today about how we were able to take the great framework that was created by the Northwest Healthcare Response Network and apply it practically through the creation of institutional infrastructure. As you heard, the triage algorithms that were developed were and are incredibly helpful, but they can only take an individual institution so far. And so each organization, each hospital had to figure out how to apply these guidelines in real time. So just to provide a little bit of background about the Seattle Children's ethics infrastructure, I'm putting up this timeline. The first ethics committee was convened in 1984. And then when Doug came around, he started the Clinical Ethics Consult Service in 1993. In 2004, he went on to start the Truman Catt Center for Pediatric Bioethics. And in 2007, we had a formal research ethics consult service. It wasn't until 2021 that we established a formal organizational ethics consult service. So importantly, between 1993 and 2021, many organizational ethics consults were conducted under the clinical ethics umbrella. And when I completed my training in 2018, I was really drawn specifically to organizational ethics because of the broader impact and desire to create some systemic change. And so I wanted to devote my ethics time fully to organizational ethics consultation. But there wasn't really an established path to make that happen. And so I'm going to tell you about how we were able to create a formal ethics consultation arm with the help of the pandemic. So we'll focus here. I know we are on an organizational ethics consortium, but just in case there are people in the audience who don't have as much experience with organizational ethics, I just wanted to take a moment to talk about some of the differences between clinical ethics consultation and organizational ethics consultation. I think one of the things that makes organizational ethics unique is that it really is addressing ethical issues that impact populations, either of patients or of staff or of other groups. And they often involve policy analysis or development because of how we're trying to implement things on a broader level. Some of the key differences are about the nature and approach. So whereas a clinical ethics consultation may be reactive to something that's already happened, oftentimes and ideally an organizational ethics consult is one that is more proactive. And where clinical ethics consults oftentimes are short in duration, you're asked a specific question that pertains to a patient, you're able to provide an answer or guidance and move on. These organizational ethics consults oftentimes take a long period. They're iterative. You need to sit in many meetings, and they can last anywhere from weeks to months to years in some situations. And so the needs for these different consultation services are slightly different based off of the nature of the types of consults. And really critical here is that organizational ethics consults really need to be requested by someone who has institutional authority to affect change. If it's called by a family member or a bedside provider, we can talk about it, but if the hospital is not really on board, it's not going to make any difference. And so that's really a key component here. So now I really get into the story, which is that unfortunately / fortunately, the pandemic really helped us to be in the right place at the right time. A colleague of mine, Leah Krohn, we decided to write a charter in hopes of creating a formal organizational ethics consult service back in 2019. And so when the pandemic hit, as has kind of been the standard, Doug was the go-to person for an organizational ethics consult. And so the executive leadership team asked Doug to participate in all of the meetings related to the COVID-19 pandemic and kind of the emergency operations related to that. And given the ethically challenging decisions related to the pandemic, they really wanted ethics to be present at these meetings. They occurred twice a day, 7 days a week for months. And so Doug and I worked together to try and be a consistent stakeholder in those conversations. We provided guidance on a variety of things related to the pandemic. We made recommendations regarding the protection of the workforce and whether certain at-risk providers should be allowed to stay or removed from the bedside. In that situation, we specifically recommended that workforce members be provided accommodations to work in non-clinical spaces if they so chose, but that the decisions to stay at the bedside fell squarely under workforce member autonomy. We helped to develop the hospital visitor policy, given that we were a children's hospital and we weren't going to keep parents away from their sick children, unlike what a lot of the adult hospitals were able to do. We sat on a committee that reviewed visitor exemption requests, specifically for things like end-of-life care or other unique situations. However, our biggest contribution, in my opinion, was that we were able to translate the work of the Northwest Healthcare Response Network's allocation frameworks into a formal standard operating procedure at our hospital. Doug and I reached out to other hospitals to compare implementation strategies and ultimately wrote a formal standard operating procedure for triage team creation and initiation at our hospital. And this included the identification of triage team members within our institution, a process for submitting relevant de-identifiable medical information that would be necessary for determining priority, and a clear adoption of relevant triage frameworks and a process for appeal. And Mithya is going to get into this more during her part of the presentation. but we really were able to operationalize that and create it in a way where it applied to COVID, but was not restricted to COVID. As Doug mentioned, there are a lot of similar principles, but sometimes how they're going to be applied really depends on the resource. And just by the way, during this whole period of time, the charter was sitting somewhere on a desk for our request for an organizational ethics consultation service, understandably, given everything that was happening in the world at the time. But finally, in early 2021, one of our team members had the opportunity to meet with our CEO, and she took her time to actually talk about what we had been doing informally, and got us an invitation to share our vision and desire to be a formal consultation service with the executive leadership team. We pitched our value add, if you will, in May of 2021, and shared that since 2016, we had completed over 30 organizational ethics consults, and that our ideal goal was to serve the organization in a proactive manner, given the unavoidable challenges that come with the many, sometimes competing duties of healthcare and healthcare systems. So shortly after we met with the executive leadership team, we were given FTE support, and now we have 7 organizational ethics consultants that are on staff, which is pretty exciting. So by mid-2021, we had created a standard operating procedure for our hospital triage team and established an organizational ethics consult service with the goal of serving proactively rather than reactively. And we also had it built-in seat at the table for any hospital emergency where there may be ethics questions. And so with that, I'm going to pass it along to Mithya, who is going to share her experience in applying this specifically to ECMO triage. And I'll stop sharing.
Thank you, Emily. I'd like to introduce Mithya to everyone before she presents on behalf of the group that developed today's policy. And thank you both Emily and Doug for laying this foundation. Dr. Mithya Lewis-Newby is an associate professor of pediatrics and of bioethics and palliative care in the divisions of pediatric critical care medicine, as well as bioethics and palliative care, Department of Pediatrics at the University of Washington School of Medicine. At Seattle Children's Hospital, she's the chair of the Hospital Ethics Committee, as well as a pediatric cardiac intensivist and ethicist. Given her dual expertise in ECMO and ethics, she was tasked with leading the development of an ECMO triage framework and process in collaboration with other ECMO and ethics experts. Mithya, thanks very much for letting us know more about this project. Following your talk, we'll turn to Matt Wynia to lead a discussion among the panel members.
Fantastic. Thank you so much, Charlotte. Thanks so much for the opportunity to speak here today about our institution's recent experience half a year ago, rapidly developing an ECMO triage guideline in the setting of an impending supply shortage, which you already mentioned earlier. So essentially, I was a consumer or a user of all of the wonderful resources that Doug and Emily just described. So as Charlotte mentioned, I'm a pediatric cardiac critical care physician and an ethicist here at Seattle Children's Hospital. And as a pediatric cardiac critical care physician, I use ECMO a lot. And it's my dual ECMO and ethics expertise that brought me into the center of this work this past summer. I want to acknowledge right at the beginning here that the work I'm going to present today is the result of a lot of hard work and collaboration on the part of a very large multidisciplinary team. And I was the conduit for putting all of the pieces together and achieving consensus, but the credit for all of this work belongs to many. So in presenting today, I'm going to share the setting of the situation, our response, the product, challenges we faced, and lessons that we learned. I'm going to review both the process and the product because I believe both are interesting and important for different reasons. And I also think we have a very diverse audience here today, perhaps some with expertise in ECMO, but not ethics, and others with expertise in ethics, but not ECMO. So I'm going to try and cover the basics of both ECMO and triage ethics, although you've heard a lot about that already from Doug while I tell this story. So the setting. ECMO is the highest level of life support available and can perform the work of failing lungs and heart as a bridge to recovery or a therapeutic intervention. ECMO is always a limited resource, and careful allocation and resource stewardship is standard operating procedure. To give you a sense, at Seattle Children's, we have somewhere upwards of 360 plus licensed hospital beds. We have 96 ICU beds. We do 4,000 inpatient surgeries a year, 15,000 inpatient admissions per year, and we are an ECMO referral center for a 5-state region, the WWAMI region. And we have 11 ECMO pumps, 8 at the time of this work this past spring. So bumping up against resource limitation in ECMO provision is nothing new. We've had the hand-wringing of one pump left many times, and the last winter's ICU nursing shortage. And in fact, in ECMO, it can be somewhat difficult to recognize a crisis at all, since we're often living on the edge. This past summer, a critical ECMO component was recalled by the company and the FDA and threatened a prolonged national shortage and institutional competition for parts. Our ECMO program leaders recognized the potential severity of the shortage as well as the ethical dimensions of such a shortage and contacted institutional leadership to initiate an institutional emergency response. Here's just an image of the 5-state region that we cover, that we provide ECMO for at Seattle Children's Hospital. So necessity is the mother of invention, and a looming supply shortage is the mother of a long overdue ECMO triage protocol. I joke here, but the reality is, as we discovered in the pandemic, we can think about these potential challenges ahead of time, but it's not until there's a real crisis looming that we really begin to hash out the details. Our institutional emergency response is a highly functioning system, as I quickly learned, and skilled team designed to quickly bring together a multitude of key players to quickly address an impending or current crisis. And this was my first time partaking in such a response, and I was incredibly impressed with the well-honed process. Within a day of initiation of the incident response system, a virtual meeting was scheduled with representatives from the ECMO program administration, ICU nursing leadership, ethics, cardiac, pediatric, and neonatal ICU leaders, general surgery, cardiac surgery leaders, supply chain, risk management, emergency management, internal communication, chief medical officer, chief nursing officer representative, and Center for Diversity and Health Equity. And this team was quickly tasked with providing data about the current state, creating a shared mental model, identifying challenges, identifying mitigation strategies, initiating contact with the Northwest Healthcare Response Network, and initiating discussions about ethical guiding principles for potential ECMO triage circumstances. Of all of these important steps, I want to specifically call out all of the individuals involved with developing mitigation strategies. I'm not going to be covering this work, all of the work that went into this today, but the efforts of the ECMO program administration and supply chain, and probably many others I don't even know of, were able to slowly attain supplies over the course of the shortage and avert the crisis. And those individuals are the true heroes of this story. So thank you very much. The organizational ethics team, after the first emergency operation meeting at noon, the organizational ethics team, including the health equity team, met 3 hours later that day to develop ethical guiding principles for a potential triage event. This team deliberated on a number of difficult points regarding ECMO allocation, in addition to outlining the pertinent general ethical triage principles. The team then developed a set of guidelines that were then presented for discussion at the next emergency response meeting the next day. So incredibly impressive. A couple of days later, our CMO reached out to me to take the results of the meetings and develop a triage framework that could be used if we reached a severe shortage. I was well positioned as both an ECMO provider and an ethicist to see and understand both sides of the discussion and to mediate differences of opinion. I met with additional ECMO and ethics experts to continue to flush out the nuances. I spoke with Doug and learned about his earlier work, from which I literally cut and pasted into the document. I incorporated the ethical guidelines from the organizational ethics team recommendations, and I added my knowledge and expertise about ECMO and the unique ethical challenges with ECMO decision-making from my years of academic work on this topic. It was an iterative and progressive process, and we ended up with a framework that I'll share with you in a little bit here. So this is just an image of the rapid deployment timeline. The ECMO program established a meeting on January 20th at 8 a.m. to discuss the impending shortage. and initiated the incident response team. The emergency meeting occurred the next day at noon on June 21st. The organizational ethics team met 3 hours later at 3 p.m. And a few days later, I was tasked to develop a triage framework. And a few days after that, through all of the hard preceding work in the years prior that Doug and Emily just discussed, I was able to produce a first draft of the triage protocol. What follows here is a review of the resulting framework that was reviewed, revised, and approved over the subsequent weeks by a multidisciplinary team, including the chief of cardiac surgery and our ECMO director, the ECMO clinical practice manager, the cardiac, pediatric, and neonatal ICU ECMO physician liaisons, general surgery ECMO liaison, the Center for Diversity and Health Equity, organizational ethics, risk management, and the chief medical officer. The goal of this document was to outline a consensus framework for allocating ECMO at Seattle Children's Hospital under conditions of extreme resource scarcity. I wanted this to capture all of the work that we had done and be a more generalizable, enduring framework for shortages beyond oxygenators. The intention is that this document provides a well-vetted process framework that can be applied to a variety of conditions. It's recognized that the specific conditions of any resource scarcity event will require a tailored approach. Examples of limited resources includes ECMO pumps themselves, oxygenators and other supplies, ECMO specialists, nurses, and ICU beds. This framework is based on basic ethical triage principles that we've already heard about from Doug today. When resources become scarce, medical decisions shift away from whether an individual patient might benefit to decisions about how to maximize the greatest good for the greatest number. It is important to recognize, as Doug has already mentioned, that triage processes have been demonstrated to be vulnerable to biases and inequities, and close attention should be given to preventing disparities in allocation. There are specific unique challenges with ECMO triage. ECMO is the highest form of life support, so those who are denied this intervention will likely die. Patients requiring ECMO are quite variable and complex, and there's no one-size-fits-all scoring system to predict who is most likely to benefit, therefore requiring expert opinion. Decisions to use ECMO for a patient must be made in minutes to hours under conditions of a significant patient instability and at all hours of the day. Use of ECMO is unpredictable, and there may be large numbers of patients who need ECMO in a similar time frame, or there may be very few. And rarely do 2 or more patients need ECMO at exactly the same time, so patients will need to be compared to a decision algorithm and not each other. And there are many teams that utilize the same resources, but under typical conditions do not communicate with each other about individual ECMO decisions. Mitigation strategies, as already mentioned, are the most critical aspect in a shortage event to attempt to avoid the crisis. When resources are anticipated to be scarce, every effort should be made to increase or conserve resources. And this may include alterations to standard protocols and the use of alternative non-standard supplies or other resources, and assessment of regional capacity and development of collaborative allocation strategies that we've already heard about today. Resource scarcity may impact all ECMO scarcity may impact all regional institutions equally, or scarcity may be localized. So to optimize the number of lives saved, regional institutions who offer ECMO in our region ideally establish a clear line of communication and plan for resource sharing. And this did occur through the Northwest Healthcare Response Network. So contingency and crisis determinations. So the ECMO program really needs to predetermine the conditions of contingency and crisis. Oops. I just lost my ability to forward my slides. There we go. Contingency is triggered under conditions, as we already heard, of a moderate resource scarcity and prompts changes in usual protocols and practices in order to conserve resources and continue to provide ECMO to all patients who will benefit. And we had a lot of discussions about this, which I can't go into today. A crisis is triggered under conditions of extreme resource scarcity and prompts activation of the triage team and triage protocols. ECMO allocation shifts, as we've already heard, to community-centered decision-making focused on saving the most lives. There's a lot of pre-crisis planning that should go into the triage protocol. For example, the team should predetermine which ECMO services will be provided or eliminated under crisis conditions. The ECMO program should determine how many, if any, pumps should be set aside and reserved for specific considerations, knowing that some patients who might have survived will not be supported by these resources. And predetermine general categories of neonatal, pediatric, and cardiac ECMO patients based on likelihood of survival to discharge and anticipated duration of ECMO. A triage team and allocation processes must be predetermined before crisis conditions occur. And the institution should prepare communication strategies as well as anticipatory support for families and workforce members under these unfortunate circumstances. And a family support team should be defined prior to crisis conditions to quickly be available as needed for families of children who do not receive ECMO or are removed from ECMO. There are some general triage ethical principles, which Doug has already covered, so I'll just glance over this in the interest of time, which are the principles of utility, the duty to care, the duty to steward resources, distributive and procedural justice, transparency, consistency, and accountability. We also identified additional applications of ethical principles to the allocation of ECMO at Seattle Children's Hospital, including children within Seattle Children's Hospital Service Region, which is WWAMI, the Washington, Wyoming, Alaska, Montana, and Idaho region, should receive equal priority for ECMO. Additional consideration should be given to children in our organ transplantation service region, which also includes Oregon and Hawaii. Saving the most number of lives requires prioritization based on likelihood of survival to discharge and potentially anticipated duration of ECMO. First come, first serve approaches are logistically simple, but unethical and unlikely to achieve the goal of most lives saved. And first come, first serve approaches often result in prioritization of patients on the basis of family resources and fewer barriers to healthcare. Avoiding first come, first serve means that under crisis conditions in ECMO, a patient with a low likelihood of survival, but who might have received ECMO under usual conditions, would not receive ECMO, even without knowing what other patients might need ECMO in the same time frame. Equal consideration for ECMO should be given to all patients regardless of the geographical location within our region, pre-existing relationships with Seattle Children's Hospital, or medical conditions requiring specialized treatment at Seattle Children's Hospital. If other regional institutions can provide ECMO and are willing to accept patients, prioritization of patients requiring specialized treatment at Seattle Children's may be considered. And quality of life judgments should not be used as exclusionary criteria under conventional standards of care or crisis standards of care. Triage team. During contingency conditions and preparation for crisis, a triage team should be established and trained to evaluate and triage patients who are considered for ECMO. The triage team has to be small enough and nimble enough to make an urgent decision, but large enough to have sufficient perspectives represented. Triage team members should be educated in triage ethics and health equity, and should be vocal and collaborative, and should focus on fair allocation without favoring their own patients or programs. The triage team for initiation of ECMO should include the following representatives: triage ethics expert, the Center for Diversity and Health Equity representative, dual-trained ECMO and ethics expert, neonatal, pediatric, cardiac ICU ECMO representatives, general surgery representative, and cardiac surgery representative. This team needs to be available on short notice and day, nights, weekends, and will need backups. A larger team that includes the previous members, but also the ECMO program clinical practice manager, nurse leader, and family support team representative make up what we call the daily review triage team. This triage team meets daily under crisis conditions to review ECMO decisions from the previous 24 hours and to review all patients currently receiving ECMO to determine if patients still meet allocation criteria. If a patient no longer meets allocation criteria, then a process is initiated to consider ECMO discontinuation. Triage process that we outlined very briefly. Crisis conditions are declared by the Seattle Children's ECMO program as previously determined by the program and confirmed by the EOC and the Chief Medical Officer. Communications are sent to all ECMO providers about the requirement for all ECMO decisions to be routed through the triage team. When ECMO is considered, a triage intake form is completed and the team is activated. Initiation triage team members meet within 10 minutes with the patient's attending ICU physician and surgeon, if applicable, to discuss the case. The triage team then categorizes the patient into an allocation tier, reviews ethical or equity concerns, and makes a determination of candidacy. The hospital leader on call makes the final decision and communicates this to the patient's physician. The triage team, hospital leader, and the attending physicians will huddle to determine how this decision will be communicated to the family. All decisions should be documented, and the time to decision should be less than 45 minutes from the time of the initial call. There has to be a fair process for appeals of triage decisions for patients' families and medical teams who disagree with the triage team decision. For initiation triage decisions, there's rarely sufficient time to support an appeals process. For decisions regarding withdrawal of ECMO, a rapid appeal process should be established. And triage team decisions should be reviewed regularly by an institutional body to ensure that the ethical and equity principles are being met and that the processes are being upheld. The next few slides are just tables we had within the document. I'm not going to go over these in detail, but essentially here we outline general ECMO eligibility criteria that are fairly standard nationally. Here we developed a table for the potential for using ECPR, which is ECMO CPR, which is ECMO that's initiated while a patient is undergoing active CPR. If provided during crisis conditions, highly restrictive inclusion criteria. And I'll talk about that in just a minute. Here we developed a table, sample categorization system, and distributed this actually to the NICU, PICU, and cardiac ICU teams to fill out with patient categories based on likelihood of survival to discharge and anticipated duration of ECMO. And lastly, here is an example of triage intake form questions that could be used in the event of needing to triage. So the last couple of slides are challenges and lessons learned. So challenges, we didn't always agree, and we still had to come to a decision. One of the biggest challenges was avoiding first come, first serve, perhaps the most challenging issue to address in ECMO, particularly because patients present sporadically. If we restrict to only children most likely to survive, then a child with a lower but not zero chance of survival might not receive ECMO, even though they may be the only one to need it for the next 2 weeks, for all we know, without detriment to others. And then we have not achieved most lives saved. But to put children on ECMO, first come, first serve, means that a pump is not going to be available to the next child with potentially a better chance of survival, given a slower process of discontinuation and a more rapid process needed for initiation. There were diverse opinions about prioritization of patient populations, with some feeling all children in the WWAMI region should be prioritized equally, and others who wondered if children with specialized conditions treated specifically at Seattle Children's Hospital, such as congenital diaphragmatic hernia and congenital heart disease, should be prioritized, particularly fetuses who were already in our system and expected to need ECMO after birth. There were also diverse opinions about outcome measures, with some believing that predicted survival to discharge was the most fair and determinable outcome, and others who felt that a goal of surviving with a good functional outcome was important. This opened up important conversations about quality of life determinations and the role of triage, and there was not consensus opinion on this topic. It was challenging to determine what degree of supply shortage should trigger crisis standards of care, given the immense implications of that declaration. ECPR, or ECMO, initiating ECMO while a child is undergoing active CPR, was a topic of good debate. Under certain conditions, such as an acute arrhythmia in the cardiac ICU after cardiac surgery, ECPR can have excellent outcomes, perhaps better than many other conditions. However, there were valid concerns about the lack of procedural justice with no time for the triage team to evaluate. This pointed out competing priorities of most lives saved versus procedural justice. How many pumps should be held in reserve For example, for cardiac surgery or for pump exchanges for patients already on ECMO. Pediatric cardiac surgical programs require ECMO rescue. Should the surgeries proceed without rescue ECMO available? Or should the surgery program pause? Or should pumps be held in reserve, knowing that some children might not receive ECMO who could have survived? And of course, the essential question of how will the triage team actually function, which I will say, never tried out. Could we actually discontinue ECMO in these circumstances? This was a very difficult situation to visualize. And finally, how do we avoid providers from triaging at the bedside when a crisis is looming? Well-intended ECMO providers brought the impending shortage into the decision discussion at the bedside even this past summer without applying the procedural justice needed to make these decisions. Learnings. There's no need to recreate the wheel. Use all of the available resources. Some decisions are very difficult to make until there is a crisis. And all efforts at mitigation strategies were the most critical and fortunately successful, and the details matter. And the extraordinary speed of this response can be attributed to many interlocking pieces that Seattle Children's built over decades. A strong ECMO and ethics programs built through intention and dedication by courageous and visionary leaders. An institutional culture of ethics so that clinicians readily recognize ethical and value-based decisions. Embedded ethicists with subspecialties throughout the hospital that can blend clinical and ethics expertise for a precision response, supported by the Truman Catt Center and the Division of Bioethics and Palliative Care. A robust institutional emergency response system. Organizational leadership that's committed to robust ethical decision-making. An established and respected organizational ethics consult program and Center for Diversity and Health Equity. All of the triage process work completed by Doug Diekema and others during the pandemic. The Northwest Healthcare Response Network, and a collaborative work environment with close connections with all of the ethicists and ECMO leaders across the organization. The caveat, we haven't taken this puppy for a spin yet, so I'm just acknowledging up front that I am sure we didn't get it all right, and that in practice we would find things that we would need to shift. So in answer to the original question, what does it take for institutions to be ready? As a recent user, I think it takes all of these factors to be ready for the next acute shortage. Each shortage from ECMO to chemotherapeutics will have unique nuances, but we'll be ready because of all of these systems that are already in place. Again, I was a conduit of this work, but this rapidly deployed framework represents the thoughtful, dedicated, collaborative work of many, many diverse individuals, all highly trained experts in their fields. Thank you so much for allowing me to share our work with you today.
And I really appreciate the work that's just been presented. Doug, Emily, Mithya, just incredible, the scope and depth really of thinking that you all displayed in the last 45 minutes is just extraordinary. I had two things that I was going to say, but in actually hearing you, based on our prior conversations and getting ready for this, actually listening to you all speak, I now have 6 points that I want to make or comments, and then I've got a dozen questions which we undoubtedly will not get the chance to go through all of, because we also want to reserve some time for audience Q&A. I'll just start with a very big picture observation. I think as Doug and each of you in one way or another sort of referred to this idea that when we're in a crisis circumstance, we as clinicians have to sort of shift our thinking, and that at some point there's a trigger or a moment where we turn from an orientation towards doing the best we can for the one person sitting in front of us without regard to everyone else, and sort of blocking out the rest of the world and just focusing on that one person. And all of a sudden, all those other people come into the room and we have to turn around and pay attention to the rest of the world and not so much to the one person sitting in front of us. And I have increasingly begun to wonder if that is, while accurate in many ways, a counterproductive way of thinking. And the way in which it may be counterproductive is that there are, times during every day when I have to say, you know, this patient would benefit from another 15 minutes of my time, but I have 8 other people I still need to see on rounds, and we're going to need to move on now. And maybe I'll get a chance to come back later. Did I just make a triage decision where I put the needs of the many ahead of the needs of the one? Or, you know, our entire antibiotic stewardship program, which often puts the needs of the many over the needs of the one in very explicit ways. Or drug shortages. I mean, we have drug shortages all the time without declaring crisis standards of care. And we have to make decisions about who's going to get the doxycycline right now when, you know, we've got Cipro, and so maybe we can switch over to that for some people. And we realize that not everyone is getting perfect, you know, care that's optimized to them, because we do have a community that we serve as well as serving the one individual sitting in front of us. And we saw such a hesitancy during the pandemic to move to crisis standards of care, to move even to recognition that we were in contingency care sometimes was a challenge. And so I've started to wonder if we should be thinking about this more in the way that we think of surge capacity, that it's not a sudden shift from one thing to the other, and we have to, you know, flip our thinking. It's more a gradual process in which we take increasingly stringent steps, right? When we get to here, then we need to do this. When we get to here, then we need to do this. When we get to there, then we need to do that, rather than making it into such a big deal. I'm just reminded of the number of times during the pandemic when clearly states and communities were in crisis, and the governor would not declare crisis standards of care, or they would declare crisis standards of care, but then say, but, you know, it's really up to every hospital to decide how to manage this and decide whether they're in crisis. And those of us, you know, who spent all our time thinking about this, were like, wait a minute, you can't declare crisis standards of care across your state and then leave it up to the individual hospitals to decide whether they were in crisis or not. If we're in crisis, we're all in crisis, because that triggers all of the sharing strategies that are so critical and which you all emphasized. So anyways, that's just one sort of overarching thought. A second overarching thought relates to equity and the sort of structural inequities that we all recognize in Mithya. I think you maybe were the most explicit about talking about this in terms of first come, first served, and the ways in which that can reinforce some of the structural, you know, racial, economic, geographic disparities that we see across our healthcare system every day, and that were magnified in the pandemic. In part because of this. And I think those are really important things to bear in mind. And also important to bear in mind, what if those most likely to survive until discharge on purely physiologic parameters are almost all white, wealthy people? And we have now created this whole structure that is purely based on physiology and says we only give resources to those who most likely to survive if they're given those resources. And it turns out those are all white people. So, and by the way, that is what happens, right? So this is not a hypothetical. This is in fact what happens, and you can prove this by doing just a little bit of math, right? You can show that people who are white and more well off and live closer to the hospital, live in urban areas and so on, they're more likely to respond to public health messaging. They are more likely to show up at the hospital. They are less likely to have comorbidities. They're more likely to trust the doctors and the healthcare, right? There are all these reasons why white wealthy people have better health outcomes at baseline, and they will also be predicted to have better health outcomes in a pandemic when critical care resources are short. And I don't have an answer to this, by the way, but I do know that we can't say we've dealt with equity by making this a purely physiologic decision based only on who's most likely to survive. it does make me think about, maybe less so for ECMO, but for other considerations, the idea of diverting resources towards those most likely to benefit is also paired with the strategy of withholding resources from those least likely to be harmed or that will be harmed the least by withholding those resources. So keeping people, out of the emergency room or sending them home, even though they normally would have been admitted, not because they're most likely to die, but because they're least likely to die, even if they don't get usual care. That's a strategy that may actually move to address some of the underlying inequities, because it would remove some resources from people who can probably get away with it. Just a thought. The next sort of broad observation is around transparency, and this will be my last broad observation. Then I'll turn to questions. It pains me to say this because we care so much about honesty in the world of ethics, but there is a reason why over and over again during the pandemic, we saw implicit rationing take place, where we did not tell people that normally you would be getting a ventilator for your mom right now. And I don't mean I can't actually say that I did this, but data show that this happened. People were not told you are being triaged. They were told, I'm sorry, your mom won't benefit from this. And that's why we're withholding it. Not there's someone else who might benefit more, who has a greater chance of survival, but under normal circumstances, we'd be giving it to you. People can't say that. It's really like, how do you say that to someone? And by the way, would that be kind? Is that a good thing to do? To tell someone, well, we could have done this, but I'm sorry, there are other people. Or by the way, as in the protocol here, there's not another patient who needs it more, but there might be later. We don't know yet, but we have to hold this back from your loved one because there might be a hypothetical person who might come down the pike who might need it. Imagine that conversation in real life. That conversation does not happen in real life. In real life, we tell, what you might call beneficent deception, right? We don't tell people the whole truth, apparently, because we didn't. Many people had services withheld during the pandemic, and it was not made explicit. And I'm not necessarily defending that, but I am kind of defending that because I don't know if I would want to know. If it were my dad or my mom, I don't know if I would want to be told the blunt truth of the situation, which is, your dad doesn't have a very good chance at survival here. And there might be someone else who can get better use from this machine or this drug. We don't tell people that we have very good information on this from drug shortages. We never tell people, well, normally we would be giving you drug A, but drug A is in shortage, so we're going to be giving you drug. Not never, but that's uncommon in real practice. So as ethicists, I think, we should hold tight to the value that we give to transparency and honesty. There are good reasons for that. I'm, not generally in favor of deceiving people. And I think we need to be attuned to the very real ways in which these things play out in clinics and in hospitals and in ICUs, which is to say, one of the lessons of the pandemic, I think, is to teach us that, to put it very mildly, people have a very difficult time admitting to patients that they are triaging anything. And we need to adapt, we need to adjust to that. We need to recognize that, honor that in some way, acknowledge it as we develop protocols in which we tell people, hey, here's what we're going to ask you to do. We're going to ask you to make these decisions and then explicitly tell patients that something that might give them some benefit in some way is not going to be given to them because someone else might get more benefit from it. And what would you do, right? If you were the one who had to have that conversation with the family, because someone's going to have that conversation with the family. And that whole piece of these triage protocols, I think, has never been really built out. We tried to build it out in ours. You guys have tried to build it out a little bit in yours, but honestly, no one that I've seen has come up with, a great way to have that kind of an honest conversation with a patient whose family member is having a potentially life-saving service withheld. Okay, so those are my comments, thoughts. I do want to, I'm going to jump off from those with Doug, I guess, by starting with this question of the trigger / sudden shift idea versus the sort of surge idea, right? Which is surge doesn't happen all at once. It happens in many stages with many strategies. What are your thoughts in terms of, how we talk and think about these issues broadly? Should we be moving our crisis standards of care guidance into our surge planning, where it's more of a, modulated response than a sudden, triggered shift?
I think we should. I completely agree with you. And maybe because my clinical world is the emergency department. So this happens daily. I mean, now we're seeing patients in the hallway, and an hour ago we weren't. And so we've moved right into contingency standards. We still take good care of them, but, and then the next day we're short 3 nurses. And so the nurse to patient ratio is not optimal. So I completely agree with you. There is not a switch that in most clinical settings, really matches the sort of boxes we've developed, and the notion of declaration of crisis standards of care, is, I mean, maybe it works. Yeah, I mean, it's not, I've never quite figured out when you would do that. I agreed with our governor that I think it really needs to be done regionally or statewide. Otherwise we should be sharing resources, but it can, as you've pointed out, an hour ago we had 2 ventilators and we weren't in crisis, and now we have 3 patients and 2 of those ventilators are gone, and we've got another one coming in the door, and what are we going to do? And there, to some degree there's a trigger there, but that can also be gone in 3 hours. And so this really is something I don't think we have fully, I agree with you. I don't think we fully appreciated that this is fluid and it's a continuum, and you don't go into crisis and then stay there for days necessarily. Sometimes you do.
Yeah.
So, yeah.
I think there are reasons why a statewide declaration makes sense. Because in part for the legal protections that it provides to allow for, setting up a crisis triage team and that kind of stuff. And that may be facilitative. I just wonder if that should be moved back because the idea of making a declaration that we are now in crisis standards of care statewide is such a barrier to making that declaration. New York, I think, is the paradigm example here, where they went the entire spring with, massive loss of life. Clearly, many hospitals way outside of contingency care strategies, and yet never got the governor to make a declaration that the state was experiencing crisis care. And I think, that it becomes a political barrier, it becomes a legal barrier, right? I just wonder if we should de-escalate the momentousness of it being a sudden shift. and
Yeah,
maybe
and
say,
I think
we're on this path right now. If we don't start implementing strategies, this is where we could end up. And that's my declaration, right, as a governor.
yeah, and you know, to to that point, the other thing that I never quite and still don't really have an answer to is that we've sort of designed most of these strategies to assume there's going to be a line, and we're going to be able to look at 10 people and make a determination about who gets the next ventilator. But and most of us agree that distributing on a first come, first served basis is not equitable. But on the ground, that's often the only way to implement, right? I mean, so children's, and, you know, I'd be interesting, you know, I'd like to hear from Mithya and Emily on this. Yeah. We've got one ECMO machine that comes in, and then we get a patient in the ER who clearly needs ECMO and would benefit from ECMO and would almost certainly have their life saved from ECMO. And so we give them that machine. And we don't have a line at that point, but we could in 2 hours. And so I think somebody in the chat has asked the question, so do you take somebody off ECMO now if somebody who might benefit more, which is really, I think, clinically what's more likely to confront us. Mm-hmm. And okay, we got these 20 people, who's going to get the next ventilator? Yeah.
Emily, oh yeah, go ahead, Mithya. I'd love to hear your thoughts on that.
Yeah, I mean, we wrestled with this. I mean, you know, for the entire time we were working on this framework, and I think, like everyone else, we don't have good answers for it. The best that we could come up with, and I'm sure there could be a better answer out there, was that essentially, if we're down to that one last pump and we're trying to make decisions, or however many pumps we decide there are left to start making these kinds of decisions, that you know, there's a wide variety of patients for whom we offer ECMO, some with maybe a moderate or less likely chance of survival, and some who are expected to have really great chances of survival with a good outcome. And so the thought was that you just, you know, as you surge, you start potentially, as you move into crisis standards of care, you start raising that bar to, okay, mm-hmm. those maybes who might have, maybe under standard, we'd try and see if it would work. We'd give them a time trial on ECMO, et cetera. That those we would say, well, now we're triaging out. And that's at the beginning of the decision, even if we don't have another patient to offer ECMO to, which was really hard. It's hard to imagine those circumstances. And say, for all those patients who meet this baseline criteria, then we would initiate ECMO. I mean, to that extent, then you do end up with first come, first served, you know, after that, because if there's one patient who meets those criteria, then you put them on, and then you might not have a pump for the next person who might have a better chance of survival, but that there's some sort of baseline line. In terms of discontinuing, I mean, I think ethically, it seemed like the only reasonable thing is that if someone the next day or 2 days or 3 days later no longer meets those criteria, that becomes very clear that they no longer have a good chance of survival to discharge, and these things do change over time, that the most ethical thing to do would be to remove them from ECMO. But it's not logistically possible to say, I'm going to remove someone from ECMO to give it to someone else, because the time periods for that don't work, especially in pediatrics. We're not going to discontinue ECMO in an hour. We're going to work with the family, provide them all of the end-of-life services that we can. It might be days before we could take someone off. It's really hard to imagine this occurring. And so it's not really like we can take one machine and give it to somebody else. The other thing I would just want to say really briefly, Matt, is to get to your point about transparency, about triage. And I agree with everything you said. And the one thing I'll say is that, at least in the pediatric cardiac ICU, a lot of patients' families already know about ECMO. And so this isn't, you know, so to not offer it and to not be clear about it, I think would raise questions. And we do this all the time when we talk about pediatric cardiac transplant. We talk very openly and transparently about candidacy, and that this is a scarce resource and their child may or may not be a candidate while we begin the evaluation. And I think, at least in the pediatric cardiac ICU, many patients have already been on a heart-lung bypass machine to get cardiac surgery. So I think if we were to move into crisis standards of care, I believe in the cardiac ICU anyway, that we would have very transparent conversations with families and say, we are now in a crisis standard. We don't have pumps left, and we're going to have to make tough decisions. And it's possible that your child may or may not be eligible for ECMO under these conditions.
Yeah, I think, in fairness, I think surgeons and folks in the procedural arena have much more experience than internists like me do at telling people you're not a candidate for this. And that's sort of code for, I don't think that it would be appropriate. It's not exactly saying you wouldn't benefit, but it is saying in relation to, others' time, effort, money, space, all the things that are necessary, you're not going to get it right now. So telling people no is hard. And it's especially hard to tell people no if you explicitly acknowledge, and I think it might help you if we could give it to you, but we can't. Which I think is why we say you're not a good candidate, or you're not going to be a candidate under these circumstances.
Thank you for that. Oh, sorry. Go ahead and finish, Mithya.
Sorry,
Jump in.
this is Emily. Just one brief thing, which is that I think, as was already highlighted, some of the challenges are that the indications for ECMO in pediatrics are so broad. And so this idea of discontinuation of ECMO really is dependent on the reason for going on, because in the cardiac ICU, if you go on for a dysrhythmia or for something that's going to hopefully resolve on the order of hours to days, then that discontinuation piece is very different. In the pediatric ICU, where we often have kids go on for really bad, horrible necrotizing pneumonias or other processes where we don't expect that they're going to get better over the course of days, we're talking about weeks to sometimes months before they're going to improve, then that discontinuation piece becomes trickier. And it's, are they developing other organ failures while on ECMO that I think would be an indication for discontinuing the therapy in that context. But, in terms of the resources, if you were to switch pumps or do other things, you're still going to need the same ECMO specialists at the bedside and the ventilators and other things that go along with that. And so I think that's just to speak to a lot of the nuance that Mithya highlighted that made this such a difficult thing. It's a shared resource across different ICUs for different reasons, but we all have to play together and make decisions using the best information that we have. And so we had a situation in 2018 or 19 that prompted me to start thinking about this, where all of our pumps were in use except for our one backup emergency pump. And we had 2 kids threatening need. And we had 1 kid who'd been on for almost 4 months and was not getting better. And so the question came up of, are we going to take it away from this patient to then give it to these other 2 patients who might need it? And everyone appropriately felt very uncomfortable with that. And fortunately, one of the other kids was rapidly getting better. And so we kind of pushed that kid off maybe a little faster than we otherwise would have, because that seemed like the easier thing to do than to remove it, even though the patient that we didn't remove it from ultimately died anyway. And so these are all the really major complexities that make this so hard, and why you, as Doug pointed out, have to make really heartbreaking, awful decisions that no one who went into medicine ever wants to make. And I think that's what also makes these conversations so difficult, is that you never want to have to share, there are these things that I could do, but I can't right now because of the circumstance. But I do think that, sharing that is important. And also, to one of the comments in the chat, it shouldn't be from the bedside provider. It should be from a representative of the triage team to come and say, your case has been reviewed, and unfortunately, we're not able to offer this service, so that it's not the doctor who has the relationship with that patient and family who has to convey that. And I think by removing the bedside providers from that conversation, it improves our ability to kind of honor that transparency and to do it in a way that is most supportive of patient, family, and staff members.
Thank you, Emily. I have to jump in as moderator to say that somehow we've gotten to almost the close of our meeting, and we're just getting started in a lot of ways. I know from feedback even before the group began, and from the comments in the chat, there's really a lot of people are struggling with even how we allocate ECMO when we've got our standard number of circuits and most of the people who we need to run them are available and so forth. So I know this audience could really go on, and I really want to thank the audience, the folks who have put things in the chat. Rather than try to take, half a question from someone by hand raise now, I want to invite anyone else who would have raised their hand had we had more time to just put your question in the chat, because then everybody can see it and reflect on it, even though we won't get an oral answer today. And I know the panel wants to see those questions, and I'm betting that other people in the audience will relate to them. I also want to acknowledge that, while just the very day-to-day exchanges and their policy implications that we've just been discussing are huge, we've also touched in this panel on different levels of organizational process where we think about those things. And, from the regional disaster preparedness group to the group that Mithya convened, but also in between that informal context where Emily was describing just the relationship between individual ethicists and hospital leaders, where exchanges can go back and forth and these kinds of issues can be explored. I want to thank everybody for participating in that level of exploration. I know that Matt saved one question for everyone, which I think would allow them to generalize. It's going to be a half-minute answer per person, perhaps, because I have to do a quick closeout at the end. But I wonder if, Matt, if you want to pose that question and ask our other three panel members what they would say.
Yeah, in fairness, they don't know what this question is, so you'll have to do this on the fly. But I think the question that I would love to hear each of you opine on is there one thing that you have learned ought to happen, and it ought to happen everywhere? Right? One thing that you've learned out of this that you would say this would apply to pretty much any hospital, and maybe we'll say any hospital that with ECMO capacities. But is there one thing that you derive from this whole experience that you say, this really ought to happen everywhere?
As a recent user of this process and not one who was part of developing all of these things, I would say that having and I am not, nobody asked me to say this or paid to say this at this organizational ethics consortium, but having an organizational ethics team and a health equity team that are robust and respected by organizational leaders was, to me, sort of the crux of being able to put this all together quickly.
Of course, I love that answer. Emily, what do you think?
Yeah, I agree with Mithya. I would just say that as we discussed, the goal of organizational ethics is to be proactive. And I think that one of the things that was really helpful and made it so that we actually never had to implement this triage protocol was that we were thinking about things ahead of time and in advance, so that we didn't have to get into these questions of bedside rationing, because that's where the inequities are going to come out. That's where the disparities are going to widen. And so having things in place prior to the urgent need, I think, was really critical in this context.
Doug?
I'll answer at a bigger level and just say that I think in a more ideal world, there would be broader networks. I think it's extraordinarily hard to have a system that even approximates fairness when every institution is doing their own thing. And so the broader you can make collaboration, the more fair things are likely to be. Even if the only thing a network does, like the one we have in Washington State, is provide situational awareness so that we know where there are spare ECMO units and where we might be able to transfer patients at a much easier level than just having a provider have to get on the phone and
Yeah.
start trying
Start
to make.
making calls. Yeah.
So that's what I would
Yeah,
say.
we're seeing some of the good answers to this question in the chat as well. And I'll just say the one thing I would add to what you all just said to build on it is I think it would be really helpful if we had more people trained in public health and organizational ethics. I mean, we have a ton of people who are trained in clinical ethics. It's become, an industry to train people to be clinical ethicists. And we have zero formal training programs on public health ethics, which is kind of what we're talking about here. I went looking for like a master's in public health ethics the other day. There are none. There are programs where you can take coursework in public health ethics, of course, but I just feel like there's a gap in our ethics training actually around these kinds of issues. So anyways, that's the lesson that I'm taking away. Shar?
Thanks, all of you. Yeah, Matt totally agreed. And Doug, Emily, Mithya, those are great concluding comments. I'll say quickly on behalf of the consortium that we thank not only our panel, but our audience for spending your time with us and putting your comments and questions in the chat, which really do give everyone food for thought. For those who would like to revisit the session, there'll soon be a recording posted on the YouTube channel for the Harvard Center for Bioethics. Our next two programs are focused on health equity, first in digital health and then in the relationship of medical and social care. Details will be forthcoming on the website, and we hope to see everyone again. Thank you so much, and this meeting is adjourned.